Multi-bypass using lumen-apposing metal stents to maintain luminal continuity of the gastrointestinal tract in a patient with altered anatomy. Endoscopic palliative treatment has to ensure a good quality of life with minimal morbidity and mortality. Stent placement is commonly used in gastrointestinal obstruction with a high clinical success rate and a low rate of morbidity. The use and indications of lumen-apposing self-expandable metal stents is increasing. A 44-year-old woman with a history of Hourneaux gastric bypass 10 years prior presented with new-onset abdominal pain. 1 month prior to presentation, she underwent radical cytoreductive surgery for advanced metastatic ovarian cancer, including hysterectomy, left colectomy, omentectomy, splenectomy, and distal gastrectomy of the remnant stomach. CT scan and endoscopic evaluation were requested. The CT scan clearly showed an expanded and isolated remnant stomach full of fluid. The patient was not felt to be a surgical candidate due to her comorbidities. Options for interventional radiology were not acceptable due to possible location of the remnant stomach. In this picture, you can see the anatomy before and after the cytoreductive surgery, showing an isolated remnant stomach. After the CT and endoscopic evaluation was performed, an enteroscopy and fluoroscopy procedures were performed to confirm that the remnant stomach was completely isolated. After the confirmation, an US-guided gastrogastric anastomosis with lumen-apposing metal stent was performed to drain the remnant stomach. In this picture, you can observe the technique used. In this procedure, we use the cold lumen-apposing metal stent system because the hot system was not available at the time. In this case, both systems could be used. However, as the remnant stomach was distended with fluid, an electrocautery enhanced system would likely be more efficient. During the endoscopic ultrasound, we visualized the remnant stomach full of fluid. First, we performed the puncture with a 19-gauge needle, followed by contrast injection to confirm the right target. Then, a guide wire was placed, followed by dilation of the tract. After that, the lumen-apposing metal stent was placed. First, we opened the distal flange. Then, after the adequate position of the stent, we deployed the proximal flange. In the video, you can easily observe the second flange being deployed. After the stent placement, you can observe the fluid being drained. Additionally, we dilate the tract with a 15 mm hydrostatic balloon to decompress the remnant stomach. After 3 months, the patient reported improvement of symptoms, and an upper endoscopy for re-evaluation and stent removal was performed. During the endoscopy, just a small amount of fluid was found in the remnant stomach, and the stent was removed. 1 year later, after gastrogastric stent removal, the patient reported ongoing improvement of abdominal pain. However, she had foul breath and recurrent nausea and emesis. The patient was then referred to endoscopy for evaluation. A gastrogastric fistula stenosis was found and a hydrostatic balloon dilation was performed to access the remnant stomach. Due to the large amount of food in the remnant stomach and patient symptoms, an US-guided gastroenterostomy was then performed to improve drainage of the remnant stomach. The intention to perform the gastroenteroanastomosis was to restore the gastric bypass anatomy. First, we perform an enteroscopy for contrast infusion. Then, with the US visualization, we find the enteral limb distended with contrast and find an adequate position to perform the electrocautery puncture with no guide wire placement. After Doppler evaluation, to avoid large vessels, the distance between the remnant stomach and the limb was measured to make sure it has less than 10 mm. After these steps, the last step consists in create the anastomosis with the stent. We used the electrocautery LAMSs to perform the puncture, and then we deployed the first flange. After the first flange deployment, with the US and endoscopic guidance, The second flange is deployed, as you can clearly see in the video. Then, a hydrostatic balloon dilation of the lumen-apposing metal stent was performed, followed by the endoscopic confirmation of the correct position of the stent. Subsequently, she had improvement of symptoms with good tolerance of oral intake and when maintained for approximately 2 years. She then developed recurrent postprandial nausea and emesis, and an upper endoscopy was again performed. In this procedure, stenosis of the gastrogastric fistula and the gastro-jejunal anastomosis were diagnosed. First, we dilated the gastrogastric fistula to evaluate the remnant stomach and the gastroenteral anastomosis. The remnant stomach had no fluid, and the gastroenteral anastomosis was patent. However, there was a substantial tissue growth in the lumen-apposing metal stent. In this close view, there was no signs of obstruction, allowing passage of gastric fluid, which was the primary reason of these procedures. Due to her symptoms and to the normal remnant stomach without dilation or food impaction, we perform a dilation of the gastro-jejunal anastomosis with a lumen-apposing metal stent. The first flange is deployed in the jejunal side of the gastro-jejunal anastomosis and the second flange in the gastric pouch. After LAMS placement, we dilate the anastomosis with a hydrostatic balloon. This picture shows the final appearance of the pouch after the procedure. In summary, 3 LAMS placements to treat obstruction at different locations in the GI tract were performed. First, we performed an US-guided gastrogastric anastomosis. Second, an US-guided remnant gastroenteral anastomosis with electrocautery enhanced lens was performed. And finally, a post-Hourneaux gastric bypass gastro-jejunal anastomosis stenosis was treated with LAMS. In all cases, a 15 mm lens was used because we think that this size has a good balance with easy deployment and caliber. During the initial follow-up, with the gastroenteral and gastro-jejunal stents in place, the patient had no symptoms and was tolerating soft foods. Unfortunately, she died 2 months later due to progression of her disease after surviving over 3.5 years with the palliative stents in place. Endoscopic therapy provided palliation with improved quality of life for this patient who was left with limited options. Lumen-apposing metal stents are proving to be useful for a variety of palliative indications, including as enteral stents and in anastomosis creation. Stent cover breakdown can occur with prolonged placement, and this should be considered in patients who respond well to therapy.